Good morning. My name is Isabel Scott and I am one of the advanced clinical practitioners working in A&E at the Norfolk and Norwich Hospital. In 2017, our team opened the first emergency department for older people's medicine with a view to get expert geriatric care as soon as patients arrive in hospital. In this presentation, I would like to discuss the term frailty, the link between frailty and falls, and discuss some of the support available for frail older people. So what is frailty? The term frailty is used to describe a particular state of health experienced by older people. Generally, people tend to have more long-term health conditions and more social care needs as they get older. Frailty is generally characterised by issues like reduced muscle strength and fatigue, and needing help with activities such as mobility and personal care. It is thought that around 10% of people aged over 65 are living with frailty, and this figure rises to between 25 and 50% for those aged over 85. It is really important to realise that being older and having multiple health conditions does not automatically make you frail. Like in the photos above, some 90-year-olds may be very fit, and some younger people may actually be quite frail. In practice, being frail means a relatively minor health problem, such as an infection, or a change in accommodation, or the loss of a friend, loved one, or pet, can have a severe long-term impact on someone's health and well-being. And this is why it is so important that people living with frailty have access to well-planned, joined-up care to prevent problems arriving in the first place, and a rapid, specialist response should anything go wrong. Someone living with frailty may need to adapt how they live their life and find new ways to manage day-to-day tasks. This can be true for their family too. There are lots of different definitions of frailty, but commonly seen problems are falls, when people collapse or feel like their legs are weak and giving way, or another sign is problems mobilising, finding that you are not able to get around the house like you used to, or are getting stuck in the chair. People living with frailty often find they struggle to manage their bladder and bowels, with incontinence meaning people might struggle to get to the toilet in time, or may need to start wearing pads. Frail people are more likely to become muddled or confused, and are also prone to side effects from medications, which could make them dizzy, sleepy, or increase their risk of falling. Doctors and other clinicians use scoring systems to help them establish how frail a person is. This allows us to work out how much help a person is needing to be able to manage their day-to-day lives, and also allows us to understand how a patient's frailty is progressing. The Comprehensive Geriatric Assessment is a tool which has been developed to help clinicians in hospital and in the community understand and meet a frail patient's care needs, with an aim to help people keep their independence and stop people becoming more frail. Rather than just looking at a person's physical needs, such as looking after their heart and lungs, this assessment should also look at other important factors which help keep a person healthy, such as diet and exercise, asking people about their mood, are they confused, are they lonely, and also looking carefully at medications to work out if any changes should be made. The slides above illustrate how this assessment can help tailor care to each person's unique needs, helping them to get the help they need to allow them to live at home more safely and reduce their risk of needing to come to hospital. I wanted to introduce you to the Older Persons Medicine team at the Norfolk and Norwich Hospital. Our team is headed up by specialist geriatricians who are the experts in care of older and frail people. We also have a team of doctors and advanced clinical practitioners such as myself, as well as therapists such as occupational therapy and physiotherapy, who are able to look at mobility and care needs and can source care and equipment for discharge if needed. We have specialist pharmacists, nurses and healthcare assistants, and are also able to liaise with other services such as the Intensive Older Persons Support Team, who support patients with dementia, our local mental health team, and other clinical and surgical specialities, dietitians and speech and language. Here are some photos of our team at the Norfolk and Norwich. The A&E department, known as OPED, is supported by our Older Persons Ambulatory Care, known as OPAC, area, which allow patients to get extra assessments from physiotherapy and other clinicians out of the stressful A&E environment. We can also bring patients to our Older Persons Assessment Service, known as OPAS, which allows them to be seen by an expert geriatrician without needing to come to hospital. It is thought that 5 to 10% of people attending A&E and 30% of all patients admitted under our acute wards are older people living with frailty. The fastest growing age group in the UK are those people who are aged 100 years old and more. This means that as well as more telegrams being sent from the Queen, there are going to be a growing number of frail older people needing specialist care. Over the last 5 years, attendances at major A&Es around the country has risen by over 10%, which amounts to over an extra 4,000 extra people attending each day. The current guidance also suggests that this number has gone up even further due to the coronavirus epidemic. Many frail older people in hospital spend up to 83% of their time in bed and a further 12% of their time in chairs. Most older people walk only a few steps a day during their hospital stay. This inactivity can lead to something called deconditioning, which causes people to lose fitness or muscle tone through lack of exercise. In frail people, being in a noisy, unfamiliar environment can also make them more muddled or confused, and they are more likely to fall when they do not have their own familiar furniture and home set up around them. There is also an increased risk of infections in hospital. Again, this illustrates why the comprehensive geriatric assessment is so important, to provide specialist input which enables people to get back to their own homes as soon as possible and keep their independence. Falls account for over 600,000 A&E attendances in the United Kingdom annually. Public Health England reported that an estimated 50% of people aged over 80 fall at least once a year. And it has been reported that when older people fall, it then provides a major risk factor to actually have future falls. Studies have demonstrated that within 6 months of an A&E discharge, fall recurrence rates range from 14 to 48%. Recurrent falls can have serious consequences for older people, such as injuries including fractures and increased hospitalisation. They are also associated with reduced functional ability and unfortunately death. In addition to being detrimental to an older person's physical health, recurrent falls can also have a negative impact on their mental health as well. Recurrent falls can lead to an increased fear of falling, which can result in activity avoidance, social isolation, and increased frailty, all of which in themselves can increase an older person's risk of falling. Falls are caused by a combination of different risk factors which are linked to the patient themselves and their environment. Patient factors include muscle weakness, gait and balance problems, poor vision, osteoporosis or brittle bones, and chronic conditions such as arthritis, dementia, previous stroke, diabetes, and incontinence. Environmental factors include such things as poor lighting, uneven surfaces, use of walking aids such as frames and sticks, lack of supportive equipment such as toilet seat raises and grab rails, for example, and poor footwear. It is also recognised that a proportion of people fall due to a single identifiable event, such as a collapse, which could be heart or blood pressure related, for example. So what can we do about it? In hospital, we carry out something called a multifactorial falls assessment. This will include looking at the history of falls, so to establish whether there's any particular pattern, such as people falling at night or in a particular room, for example. We also looked at signs of infection. As an example, a urine or wee infection can make you feel dizzy or confused, which could increase your chances of falling. We look at people's hearts. Blackouts, especially if you're not able to remember how you fall, can be a sign of heart-related issues. There are also problems with blood pressure, which can make you feel dizzy and lightheaded on standing from a chair or when getting out of bed. As people get older, they tend to take more medications as they have more chronic long-term conditions. It is known that taking 4 or more medicines can actually increase your risk of falls, and certain types of medications themselves can increase your risk of falling. Things like antihistamines, for example, can make you feel drowsy. Poor memory could impact your risk of falls, as many people forget to use their walking aids, for example. And people who have mobility, strength and balance problems and are therefore unsteady are obviously at risk of further falls too. Other commonly seen issues are environmental issues such as trip hazards in the home or poor lighting, toileting issues where people need to go to the toilet more frequently and risk having either accidents or rushing, increasing their risk of fall. Poorly fitting footwear increases your falls risk, as does pain in your feet, and also vision problems such as being partially sighted or not wearing appropriate glasses. So now we have identified some of the things that increase the risk of falls. What can we do about them? Well, subsequent falls interventions could include treating infection with antibiotics, referring any heart-related issues to cardiology, such as patients who require a pacemaker, for example. Problems with blood pressure can often be sorted out by reducing blood pressure tablets and increasing fluid intake. And medication review, so actually stopping or starting tablets, can help reduce the risk of falls. Patients who have memory issues should be referred for what we call a memory matters, which will investigate any underlying dementia. Subsequent falls interventions could also include physiotherapy referral for exercises and walking aids, referral to occupational therapy to look at things like toilet seat raises or a bed lever, and advice regarding environmental risks such as trip hazards. There is also something called assistant technology, such as pressure mats to alert people when patients are getting off the bed, or alarms that patients can press if they have fallen or need help. We are also able to refer patients to the continence team, who can look at bladder retraining and exercises to improve your bladder control, and also things like incontinence pads. It is important to ensure that footwear fits correctly and has non-slip soles. We would advise avoiding walking in socks or tights, as these are more slippery. And people should also be referred to the podiatry team if they have things like ingrowing toenails or painful calluses. Any visual problems should be directed towards their local optician. None of us can stop time, and we will all get older. Although we cannot stop the ageing process, there are strategies available to help older people maintain their independence, reduce falls, and slow the progress of frailty. I hope this presentation has been informative and has given you some understanding of the link between frailty and falls and some of the interventions and help that are available. I will leave you with some pictures of our more unusual visitors. Thank you for listening.